You're listening to Streetside, a Street Medicine Institute podcast.
Welcome to Streetside, the official podcast of the Street Medicine Institute, conversations at the intersection of healthcare, homelessness, and humanity. Our guest today is Dr. Benjamin Hayes. Dr. Hayes is an assistant professor in the Division of General Internal Medicine at Montefiore Einstein Hospital and a physician at OnPoint NYC, where he works at the intersection of primary care and harm reduction to improve care for people with opioid use disorder. He is an NIH-funded researcher and focuses on expanding access to buprenorphine, including innovative low-dose initiation models in non-traditional and inpatient settings. He'll be interviewed by Ryan Daly. Ryan is a fourth-year medical student at Albert Einstein College of Medicine, applying to emergency medicine residency with an interest in addiction medicine and harm reduction. Ryan worked in homeless services in the Southwest and Northeast before enrolling in medical school. Welcome, Dr. Benjamin Hayes and Ryan Daly.
Thank you for coming on the podcast today.
Thank you for having me.
Really appreciate you being here and taking the time to share your story and talk about the work that you do. I think the question that I always like to start with, just tell me a little bit about yourself and what brought you to do the work that you're currently doing.
Yeah, thanks for inviting me to be on here, Ryan. It's a bit of an honor to be interviewed for your really cool podcast. Well, before I came to medicine, I actually was working as a social worker. So I had trained in social work and then was working in San Francisco, doing case management and running groups and outreach and stuff like that. I would say most of the folks I worked with, I was working with HIV organizations. Most of the folks I worked with were sort of struggling through substance use and addiction and homelessness and housing and economic insecurity and food insecurity. And so although the HIV was interesting for them, it wasn't really their major issue that they were coping with because they could take their medications. But the biggest barrier to taking their medications or for stability was all these other larger issues that they struggled with. And addiction was a big one. It was something that people struggled with every single day. And there just weren't really great resources for them to cope with that. Most of the systems that were available to them were kind of had the goal, whether it was like explicit or implicit, of abstinence. And for people who weren't in a place of abstinence or weren't ready for abstinence, that just wasn't a realistic goal. So they sort of cycle through these systems and it wouldn't be a good fit and just spit them back out again. And they weren't going anywhere. Buprenorphine was accessible or was an option, but not very accessible to people at that time. This was in around 2007 and a little bit afterwards. So that it was hard for people to get clinic-based treatment that they could sort of dictate their own terms. It was kind of methadone or inpatient rehab or detox or something like that. And at the same time, I was doing some volunteer work with some agencies that were kind of doing on the street harm reduction work, handing out clean drug use equipment, but also just like building relationships with folks and giving people a place to belong and a sense of community. And, you didn't have to not be using drugs. In fact, the assumption was that people were coming to use the services because they were using drugs. But it was just a place for people to belong. And you could see really how transformative it was for people just have a space where someone saw them as a person, regardless of what was going on, and met them where they were at in their life and just said, come be who you are. We have a place for you. And we like who you are as you are. It wasn't like personality wise, there's a lot of different personalities, but it was really phenomenal to see, and it was led by some really amazing folks. The one organization that I started off with was called Homeless Youth Alliance. The executive director was and is Mary Howe, who she just comes at it with all the right perspective about trying to be there for people without being judgmental and always showing up and always being consistent. And so doing that work was just like really eye-opening for me. And it just felt like this is the right fit. This is what feels like was helping these people that we were working with in a way that just felt very open. And not exclusive and not dictating. But you could see there were so many barriers to medical care. Addiction-based medical care, but also any medical care at all. I did a focus group with a bunch of the participants of Homeless Youth Alliance, trying to figure out what was their interaction with medical care. And they all had these terrible stories about like showing up and just feeling stigmatized and people telling them terrible things and having terrible treatment. And, you know, and a lot of this was Homeless Youth Alliance. A lot of them were kids and they had dogs, and the dogs were the most important thing in their life. They couldn't bring their dogs into medical care. And you just saw that there were so many barriers to people who used drugs or were homeless simply because they used drugs and they were homeless. You know, it was just, they were like artificial constructs, largely based out of stigma and kind of inflexible systems. Um, so it sort of felt like there was a role for me in medicine, maybe that I could do, kind of bring my social work experiences and my volunteer experiences and have a perspective in medicine that would be useful and valuable about increasing access. So that's what I did. So I struggled to get into medical school, but I got into medical school, which was um, amazing. And had a great experience in medical school and just continued to volunteer doing the harm reduction work with the Homeless Youth Alliance, which was just like, I mean, that was like where I wanted to belong. You know, medical school is hard. It's like very stressful. It was very stressful for me, and being that I just feel like, you know, I'm a maybe a slower learner than some of my other medical students. And so I didn't always feel totally in place, but it felt great to have that space to go to. And I had done some work with another kind of research-based harm reduction drop-in service. And so I was able to work on a manuscript with them and publish about access to Hep C rapid testing. And so I sort of was like, well, okay, so there's a role for research maybe here and some clinical stuff, and I could see how this could make an impact. And so after medical school, I really wanted to continue doing kind of community-based addiction treatment work with maybe a research component there to explore what were the questions that weren't being asked to help people with substance use who weren't getting treatment in the way that you might see in research or evidence, who wasn't being represented in evidence. And Monty was a great fit for that because there's a really great social medicine program here with a lot of clinicians who and researchers who are leaders in sort of the field of social medicine and addiction medicine and kind of bridging the gap between clinical community-based practice and research. Came here and started doing that and got connected with Aaron Fox as a mentor, Chinazo Cunningham. I mean, I remember my interview here at Monty was with my first faculty interviews with Chinazo Cunningham, who had been at Monty for a long time, had really done a lot of street medicine around HIV treatment in SROs, just like bringing people medical care where they were at in the SROs. And she had worked with the Washington Heights Corner Project and had worked with Boom Health and like just like in my mind, like a giant in the field, and had published so many great papers, had really spearheaded buprenorphine treatment within the clinical practice at CHCC and had really kicked that off. And so I came all prepared to like, you know, have to explain who I was and where I was coming from, what I needed, what I wanted to do, and really wanted to learn more about who she was. And she spent the whole time just trying to describing the amazing things at Monty to me, like selling Monty to me. And I was like, you know, I thought, you know, I'm amazed that like, you know, you're selling this to me. I thought I was gonna have to sell myself to you. And so it was like this vibe. I was like, you know, it's not the sort of standard medical residency vibe of like you have to prove yourself. There's a hierarchy that you need to fit into. It just felt like people saw me and valued what I had done and where I was coming from. And I was like, this is a place that I could belong. This is like a good place where I can belong as a learner and develop as a clinician and researcher and that's the fit that it's kind of always been in. So yeah, so I was lucky to connect with her and Aaron and then Brianna Norton. So Chanazo's gone on. She's now like the director of uh, addiction services in the state with through Oasis. Brianna Norton was here, and she had started this collaboration with Washington Heights Corner Project and New York Harm Reduction educators at the time to do testing for hepatitis C, and they wanted to leverage that into treatment for hepatitis C. And the New York State AIDS Institute had started or was creating these funding streams for what they called drug user health hubs, where they wanted to fund low barrier clinical programs for people who use drugs to get access to buprenorphine treatment and what other medical services seemed relevant, Hep C treatment. And New York harm reduction educators kind of jumped at that, was really excited about that, and collaborated with Brianna Norton to create their first medical clinic where they could do both Hep C treatment and buprenorphine treatment, and then whatever other sort of relevant health issues for people using drugs and using their services. And they built this beautiful clinic, and Brianna invited me and Andrea Jakubowski to be volunteer clinicians in the clinic. And I was a fellow in the internal medicine. There's a internal medicine fellowship program, which is essentially it's a research fellowship. So I had a little bit of protected time. And so Andrea and I dedicated some volunteer time every week. And so Brianna had volunteered her time too. So it was the three of us doing volunteer kind of clinical services, each of us doing like a 1 day a week New York harm reduction educators. And that's how I got started at the clinic, which was just great. It just seemed like a dream fit for me. I was like, this is exactly what I wanted to do. This is where I wanted to be at. And I had a primary care practice at the FQHC at the Montefiore CFCC clinic, which I liked. I really liked the primary care, but this was just like that. It was like this was a full circle back to the harm reduction, bringing my clinical expertise to that. Yeah, so that it's just kind of like gone on from there.
Yeah, thank you for telling the story. I've always been really curious about your background and how you ended up at Monty and like the path there. Because I knew you had an MSW before school, and I always said that like some of my favorite doctors were the people who were MSWs or MSW MDs. It's like there's not so many. I think like John Giftos is the one other
Yeah.
person I can think of.
Yeah, there's not so many. John
Yeah.
Giftos. I remember actually that was the other thing. When I interviewed at Monty for the residency, he was the outgoing chief, and so he's the first person I met. And he's like, "Yeah, you have an MSW. I also have an MSW, you know." And it was like I was like, "Okay, cool. This is a good connection."
Yeah, it's pretty incredible. There are a couple things that you'd said that I'm really curious. So, what are some of those questions within addiction work that aren't being asked that you're looking to answer right now?
Yeah, so I think that there's a few things. One is, we have this amazing medication, buprenorphine, for people with opioid use disorder, which has a ton of evidence about being highly effective for so many great outcomes. I mean, reducing the risk of overdose, all cause mortality, I mean, overdose mortality and all cause mortality, increasing quality of life. It's accessible in really any sort of ambulatory clinic by a provider who is licensed by the DEA to prescribe controlled substances. Yet it's really hard for people to get onto it. And there's so many reasons for that. I mean, I think that there's a lot of barriers, again, built into the structure about people's ability to access these medical clinics, like even an FQHC will have security and front desk staff and nursing triage and waiting rooms and doctors who follow protocols and, appointment times and wait lists. And it's a huge hassle. And then it's the medication itself that's hard to start, working as a partial agonist, and it can precipitate withdrawal. And then I think there's also just a lot of people who like they're using and they're not quite ready to really engage in like what they perceive as a treatment program, or like the someone else's priorities about how to use or how to stop their drugs. So I think some of the questions that remain are like, why are only 10 to 20% of people with a opioid use disorder accessing treatment for opioid use disorder? And I think, some of those things that I listed are what we're assuming. And there's some evidence out there that those are reasons why people aren't accessing. But what else can we do to overcome those barriers? Where are the places as clinicians that we can do better? And some of that is how do we, are there other ways that we can introduce the buprenorphine medication to reduce opioid withdrawal? And then the other thing is, are there ways that we can make our care delivery structures easier to access? So right now I have a grant from the NIH to do a randomized control trial of low dose buprenorphine initiation versus standard initiation, to reduce the risk of precipitated withdrawal when people are starting buprenorphine. But then the other things that we're interested in is like, how do you do a low threshold care program? So like what we're doing at what's now OnPoint. So New York Harm Reduction Educators merged with Washington Heights Corner Project to make OnPoint a few years ago. And so we now have these two clinics there, and there we have these clinics that are embedded within the harm reduction programs in the same site as the syringe service programs and the overdose prevention center and the drop-in and case management, all these other stuff. So people can just walk right into our clinic. What role does that have in increasing access to BUP and retention and OUD outcomes? Yeah, so how do we bring clinic services to where people are? And then I think also the other question is like, how do you bring sort of harm reduction philosophy and practice into more traditional clinical practices? So how do you integrate that within basic primary care services? I think those are important research questions that some people are trying to answer, and they're hard questions to really answer because you can't always do like a randomized control trial on some of that stuff. But there's lots of ways to ask those questions and get answers.
Yeah, absolutely. And I think something that you hit upon in your answer is to like why OnPoint and the Hub Clinic are kind of like this, like living out this ethos of street medicine, which is like bringing medicine to people. You and the team like started a clinic inside of the needle exchange. Like it is two doors to get into the clinic from the main meeting area, and it's an incredibly low threshold, and like the power of that, and what it means. And you talked a little bit about how it came to be, where like and like all the big players. I'm interested to hear more about the merger between
Hmm.
Washington Heights and Harlem, and also the opening publicly of OnPoint as a safe injection facility.
Yeah, I can tell the story as I understand it. Obviously, it's probably those stories are probably better told by the people who were in the room. So New York Harm Reduction Educators and Washington Heights Corner Project. I think that at the time, their two executive directors sort of felt like by consolidating their organization, they could be more effective as, I guess, providing services at scale. And also there was a lot of expertise to be shared among those two groups. And I think joining as one, it would make that more fluid. And I think there was also a bit of a sense that their ability to advocate for their clients and make the case for the services that they deliver would be more effective as a single organization. So they merged. I think that was in 2018 or 2019, 2018-ish, to become OnPoint NYC. It was shortly thereafter that Bill de Blasio was like in his last little bit of his term, and he wanted to have, I think he wanted to make a big impact with addiction and homelessness. And this was like opening up an overdose prevention center was like probably the most low-hanging fruit for like an evidence-based intervention to potentially have a big impact on health outcomes. I mean, there's just like so much data around overdose prevention centers throughout the world over the past 30, 40 years called safe injection facilities in other places or safe consumption facilities. A lot of the data came out of Vancouver from Insight, but there's also data from like the Netherlands and from other parts of the world. Canada has really embraced it, and the evidence really has demonstrated that they reduce overdose deaths. They increase people's engagement with a multitude of services like social services, medical services, healthcare related services. They have a huge impact on reducing risk behaviors associated with the transmission of HIV and hepatitis C. There's data that they reduce kind of what might be like community level negatives that community members sometimes vibe on. So like they reduce arrests and confrontations with interactions with police in the surrounding neighborhoods. They reduce the amount of like disposed syringes and drug use supplies in the surrounding neighborhoods. There's just a lot of like public benefit and social benefit and individual benefit. It's just like an amazing public health intervention. But in the US, you haven't been able to do it for so many years because, I mean, large like exclusively because of stigma towards people who use drugs and perceptions that this sort of intervention actually facilitates drug use and encourages people to use drugs, and which stems from this whole idea based off of, well, 100 years, 200 years of discrimination towards using drugs and sort of wrapping that up with xenophobia and racism and all sorts of stuff, culminating in the huge war on drugs, which really framed drug use as like a dichotomous good versus bad. You either use drugs and you're bad, or you don't use drugs. That the only answer to drug use was criminalization and just say no. And yeah, criminalizing what could be framed as a disease or a social problem, or and it was all about being moral. So this sort of like this idea that you're going to help people who use drugs in in a and help them meet their health goals in the way that they dictate is really in contradiction with that sort of idea. And I suppose that there's community members who are just they don't like the not in my backyard sort of idea of like, I don't want there to be these social services for people using drugs in my backyard. But it manifested in this like the drug the or the what's called the crack house statute, which is a federal law that you're not allowed to let people use drugs in your property, like knowingly let people use drugs in your property. Came out of the 80s, with the idea of what crack houses and et cetera, et cetera. There have been several places in the United States that have wanted to open up a facility like this. San Francisco, Philadelphia almost opened one up, I think at Prevention Point. And then they were shut down because of this federal statute. Ithaca famously wanted to open one up, but Bill de Blasio was like, I think the Department of Public Health at New York City was like really pushing for this. They're like, we have tons of evidence about this. We've been collecting evidence with New York harm reduction educators and OnPoint about their sort of monitored bathroom settings, the reduced risks of overdose and safety, and they've got the staff there. OnPoint, well, New York harm reduction educators slash and Washington Heights Corner Project slash OnPoint had actually brought in several folks from Canada who had worked in Insight. So Kaylin C and others to just sort of help design what is the framework going to look like here. So the OnPoint was already very prepared, and they could speak to it and say, we know how to run this. We know how to get it started. So Bill de Blasio was like, okay, that's great. This is evidence-based. The Department of Public Health is telling me this is an amazing intervention. We can do this. And he put a ton of money into it and just made it happen for them. So they hit the ground running and were able to open up the overdose prevention centers with like no time at all. I mean, I think they opened it up within a matter of months. Opened up one in the East Harlem site and then one in the Washington Heights site. So yeah, I mean, it's sort of like the stars aligning, but also I think the unsung heroes of public health, sort of behind the scenes, consistently being present and doing advocacy and telling the story about evidence and people and the values of public health interventions. I think there was a lot of community work around talking with community members and community groups to sort of reassure them and not have it be a confrontational intervention, but have it be, this is a community benefit intervention. And how do we do that? And meeting those people where they're at too, like I think there's a place in time always for protest and for confronting opposing views with a voice of sort of like, posters and megaphones. I think there's a time and place for that, but also harm reduction is also about meeting everyone where they're at. And so, there are neighbors and community groups and businesses and schools, and you got to meet them where their concerns at, who, they're not reading the same data and research and Twitter feeds that we are, and they have very valid concerns. And you got to be like, yes, I hear those concerns. We're on your side. We're here trying to make the same difference you are. And I think that's an approach that OnPoint has really, really prioritized. So that's the story of opening OnPoint that I know of. Yeah. And then they could show great outcomes, and they could partner with, they partnered with researchers to demonstrate that their data, that they were making an impact, like a positive impact, which you really want to do that to back yourself up. You don't want to just open it up kind of like on the fly, not do it quite right, and be the first overdose prevention center where there's a fatality on site or something like that. That would be really bad.
Yeah, while you're talking and mentioning sites that have attempted to own or attempted to like open up like overdose prevention centers in other cities, I remember going to like a family barbecue, and my family was from Central Jersey, and some people are like a little closer to Philadelphia. and people were asking me what I thought about Philadelphia trying to open up an OPC. When I said it would be a great thing, that didn't fly so much. It was just a lot of questions afterwards.
Hmm.
I think
Hmm.
also part of the story there was a lot of pushback, didn't open up, and then the city explicitly passed a law that said this is not okay in our city.
Yeah.
And talking about like other models, I worked in Boston for a while at healthcare for the homeless, and I'm pretty sure it's because of the crack house statute. They
Hmm.
have something that's like an overdose prevention center where you can use on the sidewalk or use outside the building and come in to be monitored while
Yeah.
like I just after you use, and they have like the reverse motion sensors in the bathrooms as like a way of monitoring like an impromptu safer
Right.
space.
Which is great. It's like, you're making the most of what you have. And I
Yeah.
mean, I think probably most of these syringe service programs or harm reduction programs, they have a way of monitoring people who use drugs. Like, you almost have to, right? So every harm reduction place that I had volunteered or worked at beforehand, had bathrooms that were monitored, because you have to have bathrooms and then people are going to use in the bathrooms. And so you got to keep a system to keep people alive, right? So it's like these people are really skilled at, and this is how harm reduction has always worked, right? It's always been underneath the radar, saving lives in ways that are not always acceptable in like sort of the mainstream political eye. But now Providence has opened up a overdose prevention center too. So I don't think we're at the cusp of not in this political climate, at the cusp of like a tidal wave of OPCs opening up throughout the country. But at least there's two places in the US to demonstrate the data and make the case. Yeah. It was, yeah, that the stuff in Philadelphia was unfortunate. I mean, there's this whole backlash around this idea of crime and punishment and unfortunately, you really don't want harm reduction to get wrapped up into politics. And drug users are such a good target. People who are homeless. I mean, anyone who doesn't have like a strong voice in the political arena and is easy to sort of demonize as another or as someone with a moral failing. Like they're just such an easy target for politicians.
Yeah, absolutely. And talking about like the community work to be done too. I've worked inside of a shelter that didn't want doctors prescribing buprenorphine because of the public perception
Mm.
around of like the neighborhood around the space.
Wow, that's crazy. That's really
Yeah. And one of the doctors that I was working with at the time was just like, you can't tell me not to prescribe like insulin to a diabetic. Like this is analogous to it. Uh,
right.
and they were prescribing anyway. So you can't tell me
Yeah.
these things is a life-saving treatment right here.
Yeah. I mean, that's malpractice, right? Like
Yeah,
to withhold a treatment that will help someone. Yeah.
absolutely. I think since then, perceptions have certainly evolved. But yeah, it's like talking about the community work though. I mean, even in the Bronx, where trying to open up in a vacant building on a hospital campus, housing for people who are going between incarceration and shelter system, who are medically vulnerable, and what those public forums look like. A ton of pushback. It
Hmm.
was like an episode of Parks and Recreation where just it feels like people aren't being heard in any really meaningful way, at least in a lot of instances. And people ultimately do care. Like the concerns for it is like they don't want their like 90-year-old grandmother to be in harm's way or perceived harm's way. So I do really appreciate what you're saying there too. It's like meeting everyone where they're at.
Yeah. I mean, if you're not in the large national political sphere, most actors have good intentions. This political world, there's conversations to be had. Um, And I think the real value, like you just got to be present and it's about showing up and being consistent. And that doesn't happen overnight. It just can't. It's got to like these interventions have to happen from people who have been there and are there and have demonstrated their commitment to the community.
I've asked all the questions that I have written down. You answered some questions that I was gonna ask without even knowing it. And one of the things specifically was like the 10,000 foot view versus like the 10-foot view, like what it means for people to have this space. And also like since it was the first time in the States that a place like this was opening, like what does it mean? Same question as yesterday when we were in the focus group. Was there any question that you think I should have asked or that you want to answer?
I mean, I would say it is like an amazing collaboration to be a part of, to have a medical clinic in the same space, I like to think that that's mutual between, us as the medical providers and OnPoint as the service providers, and certainly as like the patients and participants. I mean, it just feels like practicing medicine exactly the way that I would imagine wanting to practice medicine, where I don't have the barriers that drive me crazy in a standard clinical practice of I'm where people already are. Like they're there. This is where they choose to spend their day or their time. They don't have to go out of their way to come find me, and they don't have to worry about a missed appointment. And so I can catch them in like the routine of their everyday, which is amazing just to see their routine of their everyday and like be like, oh, this is how you're living and this is what's going on in your life. And you can't see that in a standard medical clinic, right? Like it's such an artificial environment for most people's lives. And some people come meet you in a standard medical clinic and they behave in a certain way because they're like, I need to behave like this in this clinic. And you get to see 20, maybe 30, 40 minutes of who they are, and then they're gone. But that's such a small fraction of their life. To be where I'm at, I'm running into people on the streets. Like I'll walk around to get a cup of coffee or coming back from parking my car, and I'll run into my patients and we'll have a conversation there on the street and we'll talk about what's going on in their lives. And it's not always about what a medical issue they have, but sometimes it is. Or somebody will be using services in the Overdose Prevention Center, and somebody will be like, you got to talk with the doctor, and bring them over to, a few doors away to my clinic. Or I'll walk down to the Overdose Prevention Center and meet them there and, build a relationship. And for people who, we sort of talked about people who use drugs have been largely traumatized by the healthcare system and have had so much, individuals have had so much stigma that they've had to endure. And the medical system is not great for almost anyone. Like, it's just like, we have a capitalistic profit-based medical system, which just like is trying to get people in, get people out, and it's not responsive. And there's phone trees that are terrible to deal with, and like nurses who are overworked and doctors who are overworked and people just trying to get their job done and generate their RVUs. And so, but if you use drugs, some of that ill intention is directed at you because you use drugs. And then you perceive that in almost every bad interaction. And you're just like, this is not a place for me. I don't belong here. In addition to sort of like, I'm going through withdrawal, I just can't tolerate any of this stuff right now, et cetera, et cetera. And so people avoid the healthcare system, and they perceive that doctors see them poorly. They perceive that nurses see them poorly. And no one likes to be looked at like that, right? Like no one wants to interact with someone who they just in thinking in their head, this person thinks I'm an addict. This person thinks I'm no good. This person is making judgments about me. Even if you're not saying it, people are thinking like, that's what this person's thinking about me. When I'm building a relationship at OnPoint, I'm being introduced by a staff member at OnPoint who maybe they're a peer who's hired on. Maybe it's just someone who's worked there for a long time. Maybe it's another patient or participant. That person I'm meeting really trusts that person. They're like, these people know who I am. They see them every day. They're helping them stay safe and stay alive. And they know that they're using drugs. They're watching them. And then they're introducing me to this doctor. This doctor must be okay, right? Like this guy is telling me Dr. Ben is okay. You got to talk with Dr. Ben. And I trust Clara. Clara is a good person. She knows me. I've known her for years. If she's telling me to see Dr. Ben, then like she's got my best interest. And then I can sit down with somebody and just listen to them and see where they're at. And they sort of get the vibe that we've got good intentions and we want to help. And it can be really transformative. Like you just see their relationship with healthcare can change. They can be like, okay, there is some health stuff I can get addressed. And so that's really fulfilling. People come in and come out, and that's okay. And just to be like, listen, it's not about me. It's not about my guidance or my medical orders or my prescriptions or my directives. It's like, this is your health, your plan. I'm here for you. I'm always here for you. I think that's like it's a powerful thing for people to have.
Well, thanks for being on. Thanks for sharing your story and a little bit about the work that you do.
No, thanks for inviting me, Ryan. This is great. This is fun.
The Street Medicine Institute is a secular, nonpartisan organization. Any spiritual or political views shared by guests on Streetside are their own. They're offered in the spirit of conversation and should not be taken as reflecting the views or positions of the Street Medicine Institute. This podcast should not be used for personal medical guidance. Please consult your healthcare provider.